Right now, our main use for IORT is for selected cases of breast cancers, which are good risk cancers. Like we have those patients with early breast cancer, elderly age group who are ERPR positive. So, who fall under a good risk profile are the ones whom we are choosing for offering, or we are offering this IORT procedure altogether. Rest of the patients we don't offer. So it's a very selected group of patients whom we offer as far as surgical oncology is concerned. We have not started doing using IORT for other procedures like rectum and all that, because most of it happens minimally invasively in our center. So we are predominantly focused on breast. Apart from me, of course, my neurosurgery colleagues have been using for few cases. So that's a separate division altogether. Right. So you see, as a practice, for every patient that we operate or do any treatment, we discuss in our multidisciplinary team. It's a mandatory thing. So we always have it. We always discuss, and as such, we have set a criteria for that. Right. So we have set a criteria based on which we present in our MDT, and MDT says, okay, clears this particular case for IORT, and that's when it goes for IORT. So we, in fact, interestingly that you are asking, recently we had our radiation oncologist had presented in our MDT requesting a permission to start for other patients as a tumor bed boost for IORT, using IORT as a tumor bed boost, which was not accepted. In fact, because there is no evidence. In fact, unless the target B trial results come out, we don't have evidence of support, enough evidence to really use the IORT for boosting the cavities. So it was rejected. In fact, we are waiting for target B trial results, or we would like to participate in target B trial, which we are, in fact, the paperwork is still awaited. So that is how our MDT really works. What I have realized is, most of the patients want to get their treatment completed as soon as possible. They don't want to linger with treatment. So the greatest advantage of using IORT in these selected patients, target IORT, is that the treatment duration dramatically comes down. We are reducing that 25 to 25, 15 to 25 sittings to 30 minutes during surgery itself. So that's a huge difference for the patients. So because of that, eligible patients, when we offer, they latch onto it. They just want to get over with it in one single sitting, because they are selected patients. So the moment they realize, yes, I would get this benefit, I can finish my complete my treatment in one sitting, they are very, very happy to take it up. Though we do discuss rest of it. For example, these patients are otherwise candidates for mastectomy, modified radical mastectomy, or they are considered candidates for breast conservation surgery with conventional radiotherapy. So they are always made to understand all the options which are available, and when we offer this, they would prefer to go for this when they're eligible. So that's how it works. So it's all about the convenience, because otherwise what happens is, these are typically the patients who would opt for mastectomy just to avoid a 25 sitting of radiation. So they are very happy to go for it. I've had some patients who are in their 80s and all, who wouldn't want to come every day to hospital for 25 days at a go, or 15 days at a go. So these are the typical patients whom we offer, and they accept it. So in selected cases, I don't feel it's a counseling a problem at all. In fact, I feel in fact, they're very happy to accept it. If you are right now, we are the only functional IORT in India. See, it's interesting because technologically and surgically, India is very very advanced. We have hundreds of robotics units which are there, but for some reason, intraoperative radiotherapy never picked up in India. For whatever reason it is, because some things don't pick up in some countries for some reason. So, but my feeling about IORT is that there is a select group of patients, if you choose well, who would definitely benefit from this technique and technology. So my advice to my colleagues and uh, my counterparts, especially the radiation oncologists who are actually resistant to IORT. And I think most of the countries, most of the places, the radiation oncologists are the ones who don't really support IORT very much. So my uh, sincere request to them is to go by the guidelines, look at the research. There is enough evidence that it benefits certain group of patients, at least for now. Let us use it for them, let us give them the benefit. So that is my advice for to my colleagues. Every technology has a use. So and it fits into a certain patient profile, certain area, certain utility. So, and when we recognize that utility, we should be open to using that particular technology for that particular utility. So that is my that's what I would like to convey to everyone. So IORT has its role, intraoperative radiotherapy has its role in a segment of patients where there is a tremendous benefit. Just imagine, I'm doing next week a patient, I'm operating on next Wednesday. This patient has a early breast cancer. It's a small lesion, perfectly fitting in. And I am planning to send this patient's tumor for the risk profile as well, which is oncotype DX. And if this lady comes out to be a low risk profile on oncotype DX as well, her treatment is over in one day. She just goes with home with hormone therapy, which is as good as benign lump excised. How beautiful is it, isn't it? So you're making a cancer sound like benign disease. So that's the beauty of newer things and newer technology. That's where we are heading.